before we go in, let me have the pleasure of introducing our speaker today, Dr. Vani, who has done her MD Obstetrics and Gynec and Professor and HOD at Obstetrics and Gynec GMC Srikakulam, Vice President Obstetrics and Gynecology Society of Visakhapatnam. So once again, welcome ma'am for this session. And if we have your permission, we would like to launch our web page Shield Connect, ma'am, wherein we will be sharing a lot of scientific information for all of your juniors in need, and also for doctors who wanted to update themselves. And all these webinars also will be posted there if we have your consent. So we'll run an AV map, which will last for about 2 minutes, and then we'll show that.
Okay, go ahead. Go
ahead. Srikakulam AV, please. This is our web page, ma'am. From menarche to menopause, we will have all the scientific updates required, and also child healthcare. We share the inputs here. And hit escape to lose that. Yeah. Thanks so much, ma'am. So over to you without losing much time, ma'am, for your presentation. Thank you, Doctor.
So I'll be sharing my screen?
Yes, ma'am, you can.
Okay. So hope the screen is visible?
It's visible, ma'am. You can do that. Yeah, perfect.
Good evening, everybody. So I hope all of you are staying safe during the COVID pandemic. I was asked to talk about this very, very important topic, gestational diabetes mellitus. An overview of what is happening as on today, and also on some new advances that are going to take place with respect to gestational diabetes. So in the next coming 45 to 50 minutes, I think I would be completing the topic. The basis for my presentation is from the NRHM guidelines, that is the National Health Mission sponsored by or a part of the Ministry of Health and Family Welfare, Government of India. So they have given the booklet and guidelines regarding the diagnosis and management of gestational diabetes. So all these are technical and operational guidelines, which will be useful and practical, even at a primary health center level. So it is a wonderful booklet which was released in the year 2018 by the NHM, Government of India. So my discussion further would be going on these lines: definition, incidence, why diabetes mellitus in pregnancy makes it a high risk, what preconceptional counseling is required for women who are already diabetic and conceiving, what is the ideal method of screening for diabetes in pregnancy, how to manage these cases in the antenatal period, what complications antenatally and intranatally are expected in a complicated pregnancy with diabetes, and what additional postpartum care we are supposed to offer in these cases. So we'll go the discussion in the following lines. So to define gestational diabetes, it is glucose intolerance of varying severity with the onset or detected for the first time during pregnancy. So here, all of you would appreciate that the period of gestation is not mentioned here. First time detected during pregnancy, any glucose intolerance will categorize it as gestational diabetes. So this definition is on par with what is written in the guidelines. Then first we have to know the magnitude of the problem. So why it is so important and why are we talking about this today? It is a global health problem, there's no doubt about it. And all of you would agree if you see these figures. The prevalence of diabetes mellitus in the pregnancy worldwide is different in different geographic locations. This is probably because of different races and different ethnic group within a country and across countries. If you see in the United States of America itself, we have the incidence in between 3.9% in white women, and in Asian women in America, it is around 8.7%. So such a lot of difference. In European countries, it is up to an extent of 3.6%. In Australia, about 4.7%. In China and Japan, around 2+%. The variability of this different prevalence or incidence is partly because of the different criteria and screening programs those countries are practicing. So probably that could be the reason why the incidence is so much varying within different countries. If we look into Indian context, here also there's a wide variability, anywhere between 10 to 14.3%. So that is the average statistics. But if we look into the urban population, it is as high as 17.8%. In rural, around 9.9%. And in semi-urban, in between these two, that is 13.8%. So these are the statistics mentioned by Government of India itself. And the incidence is expected to rise 20% or even more in the coming next 10 years. So probably by the end of 2030, we can expect around 25% or 30% of antenatal women to have gestational diabetes. So that is the predicted or projected figures for our country. So now I think all of you would agree that gestational diabetes is a very, very important problem in pregnancy, which we have to address. So before addressing it, we should know something about this in detail. I think all of you agree with me that it is a high-risk pregnancy. So having diabetes in pregnancy is definitely something high risk. For whom it is high risk for the mother and also for the fetus. For the mother, there are n number of complications that can happen, starting from polyhydramnios, more chance of preeclampsia, and in labor, the prolonged labor because of a large baby or an obstructed labor, a high incidence of cesarean sections. Because it's a large baby and prolonged labor, there's always a chance of uterine atony, therefore atonic postpartum hemorrhage, and later on sepsis or infection. So these are some of the few important things I've mentioned regarding the maternal complications. But look into the fetal complications. Right from the start of the first trimester, spontaneous abortions, intrauterine fetal deaths, or the fetus dying while the woman is giving birth, that is stillbirth, more chance of malformed babies. During labor, more chance of a difficult labor due to shoulder dystocia, consequences of shoulder dystocia in the form of birth injuries, neonatal hypoglycemia, and respiratory distress syndrome. So these are some important fetal risks which could happen. So if we look into the pathophysiology, pregnancy itself is a diabetogenic state. So why it is diabetogenic? There are certain factors in pregnancy which rise the blood sugar levels in the maternal blood. Human placental lactogen, estrogen, progesterones, cortisol, placental insulinase, a specific enzyme that is produced by the placenta, early degradation of the insulin. So these are certain factors which tend to raise the maternal blood glucose. At the same time, there are certain factors which increase the insulin resistance. So increased insulin resistance and degradation of insulin are some de novo factors that happen during pregnancy. So therefore, the balance between the glucose and insulin is tilted. So that is why pregnancy has become a diabetogenic state. There are certain other things also which I would like to mention, that insulin resistance and pancreatic beta cell dysfunction. This pancreatic beta cell dysfunction in certain antenatal mothers, probably genetical or probably autoimmune or any underlying chronic insulin resistance, any of them could lead to gestational diabetes mellitus. So therefore, a combination of factors work for the mother to acquire gestational diabetes mellitus. I was telling you that the fetus can end up with congenital abnormalities. So this is very important to know that women having diabetes starting from the first trimester or women who are already diabetic, they have a high chance of embryopathy. So this embryopathy will result into congenital anomalies of the fetus. Majority of the abnormalities in the fetus are in the CVS, cardiovascular system, or in the central nervous system. So they are the most common abnormalities which can happen in the embryo. We already would have studied that transposition of the great vessels is a very peculiar and important effect of the cardiac malformation. Similarly, in the central nervous system, spina bifida, anencephaly, and in the skeletal system, the caudal regression syndrome, wherein the sacral agenesis can happen. So there won't be any sacrum in the vertebral column. Genitourinary tract, gastrointestinal abnormalities, any of them could happen. So that is why all treating obstetricians should have a knowledge about that congenital abnormalities are common, especially if the woman has acquired diabetes right from the first trimester or already non-diabetic. These can happen, and a thorough survey should happen to the fetus on ultrasound. The other important thing I would like to mention, it is not very new, but a concept what is called as fetal origin of adult disease, FOAD. So the disease of the adult is programmed in the intrauterine life itself. So this theory was quite old, but now gaining more importance. So this has to be learned at this juncture. So this fetal programming happens in utero itself. If we have seen the first scenario, that is an overfed state. What is this overfed state? The mother is having gestational diabetes, so therefore hyperglycemia. So here the fetus will be programmed for overproduction of insulin. So hence the fetal pancreas secretes large amount of insulin than normal to counteract with this extra glucose load, and therefore early exhaustion of the beta cells for that fetus happens, and there is a tendency for this fetus in the later life to have a future type 2 diabetes mellitus, because the pancreas fails to reciprocate the increased demand later in the life when it happens. So this is the first scenario of fetal origin of adult disease. The second scenario, that is a starved mother. The mother is having maternal starvation. Here also the fetus is programmed for underproduction of beta cells. So this underproduction program will lead to fetal pancreas to be more fibrotic and more plastic, and therefore becomes compromised. So such a fetus also in the later life have a tendency to have a future type 2 diabetes mellitus. So both the state, either an overfed state or an underfed state, will program the fetus to have a diabetes in the future. So gestational diabetes mellitus or diabetes mellitus in pregnancy can happen either. It starts from the pregnancy, that is what's called gestational diabetes mellitus, or recognized first time in pregnancy. So that amounts to around 90% of the cases. Or we may have cases who are already having a type 1 insulin dependent diabetes or a juvenile diabetes and conceiving. Or women having type 2 diabetes mellitus already on treatment and conceiving. Or rarely any other forms of diabetes mellitus. So either of the scenario can happen in the pregnancy. Gestational diabetes mother has a lifetime risk of developing type 2 diabetes in her future. So therefore, we should be concentrating at this stage in the antenatal period to detect women having gestational diabetes for having a good pregnancy outcome in that pregnancy, and not only that, also to define those cases of gestational diabetic mothers and pick them up and see that they don't have a lifetime risk of developing type 2 diabetes mellitus. So this is a wonderful slide. Please have a close look on this. The green one or the green bar here, so the dotted line is the diabetes mellitus threshold for diagnosis. If you see the green bar or the green line, we can see the arrows pointing. Even in the pregnancy, the blood sugar levels did not cross the threshold. But if you see the red bar, so this woman had diabetes mellitus in first pregnancy, even in the second pregnancy, and later on continues to have a diabetes mellitus in her future. So this will clearly say that picking up gestational diabetes mellitus in pregnancy will have a long-term effect on recognizing type 2 diabetes in the future. You may have a doubt, why don't all pregnant women develop gestational diabetes? In a normal pregnancy, the pancreas has enough functional reserve. So therefore, it would be compensating the insulin resistance that happens in the pregnancy. But in few cases, the pancreatic reserves are lower. And these cases, they develop gestational diabetes. And they also have a chance of developing gestational diabetes in the next pregnancy. And also type 2 diabetes in their future. So it is all how much reserve the pancreas is having in its beta cells. So that will decide which woman will develop gestational diabetes or not. So basically, we can understand that we can predict in which cases gestational diabetes is higher. If a woman had a gestational diabetes in previous pregnancy, yes, it is a risk factor. If the woman is having body mass index more than 25, it's an independent risk factor. And the ethnic group, that is Asian group itself, is a high risk for diabetes mellitus. If the antenatal woman is having a first degree relative having diabetes, then she is at a high risk of developing GDM. If the weight gain is more than 5 kgs since 18 years of age. So post 18 years of age, if the weight gain is higher, she is at a high risk. Women with PCOD, they are at a high risk. If the maternal age is more than 35, she is a high risk. Or if the woman had given a macrosomic baby birth in the previous pregnancy, she becomes a high risk. So these are all the independent high risk factors for gestational diabetes, and we should be surveying these antenatal women more frequently than an ordinary woman. So I think now you would have understood that gestational diabetes is an epidemic. So this epidemic is unfolding in our country right now. So this is not my statement. It is a statement given by a very important group which has studied all this. So they have studied women in India with gestational diabetes mellitus, and they have, along with the Madras Diabetic Research Foundation and Indian Diabetes Federation, so both of them, they sat together, they have done the study, and they have said gestational diabetes is highly prevalent in our country. It is a serious problem, and majority of the cases are underdiagnosed, and there is a confusion that is existing in how to screen the particular disease because of lack of clear-cut guidelines. So these are the statements which have come out of the studies done by these important two groups. So therefore, there is a very urgent need to curtail the disease. To curtail this GDM epidemic, we need to do something. What are the things we can do from our side? Universal first trimester screening. So when the antenatal woman has booked, then itself we should do screening for every antenatal woman, irrespective whether she has a risk factor or not. The second thing, use of a single step diagnostic method. Then this test should become a part of the routine assessment of all antenatal women. Simultaneously, we should be adopting certain steps for prevention and patient education. Similarly, early management of diabetes and making her as euglycemic as possible will give a good pregnancy outcome. So these are the things we need to understand. We may have patients of a significant number who are already diabetic and they have become pregnant and they want to become pregnant. So they need to know certain things before they plan pregnancy. This is what is called preconceptional care. In the preconceptional care, the women or the couple should understand that a strict glycemic control is highly essential before they plan the pregnancy. If she is obese, she needs to come down and reduce her BMI to less than 25. And we need to assess if the diabetes is also having any organ complications like kidney or fundus, retina, etc. We need to assess whether any organ complications have already set in. We need to review what oral hypoglycemic drug she is taking, or what insulin she has been using, or any other additional medication she has been using. So review of what are all the medications she is taking. Any complications also need to be counseled. And right from the preconception, she needs to take folic acid 5 milligrams per day. And we have to advise her that hemoglobin A1C is an important investigation that will tell us, or that will hint us, whether the pregnancy would end up normally or not. If the hemoglobin A1C is less than 8.5, there is a 3.4 risk of having a congenitally malformed baby. But look, if it is more than 12, there is almost a 25% chance of this pregnancy ending up in a malformed fetus. So therefore, that will set a guideline for us to see whether the fetus would be having an embryopathy or fetus would be progressing or developing normally. So hemoglobin A1C is an important investigation in a preconceptional counseling. And in assessing the complication, we need to do serum creatinine, urine for microalbumin, fundus examination for any retinal changes, ECG and a 2D echo to see whether any cardiac malfunction are already set in, and any associated hypothyroidism. So these are the other set of investigation as a part of the preconceptional counseling. And reviewing the medication. If she is taking oral hypoglycemic agents, apart from metformin and glyburide, better shift to insulin or to metformin alone. If she is using antihypertensives along with OHA, if she is using ACE inhibitors or ARB inhibitors, we have to remove them and we have to shift her to other antihypertensive drugs. All non-diabetic women who wants to conceive, they need a very thorough counseling that pregnancy would be slightly complicated both from the mother's side and the fetal side. Therefore, they need to have a strict glycemic control, need to practice certain dietary advices, need to practice certain physical exercises, and should be very, very strict, compliant in using the medications. Then, coming for screening for gestational diabetes, we have routine antenatal women coming to us in the antenatal clinic. What to do in those cases? So here we adapt to the strategy because we know in India, GDM is coming like an epidemic and we are all at a high risk. Indian women are at high risk for developing gestational diabetes based on the geographic conditions and ethnicity itself. So therefore, we have to adapt for what is called as a universal screening. That is, don't leave any antenatal woman. Every woman has to be screened. So what is the test which is recommended for screening and when to do, when to repeat? So these are the next important questions that would come into our mind. The single best test is what is called as a DIPSI test. So DIPSI is a wonderful group, Diabetes in Pregnancy Study Group of India. So they have said that in our conditions, a one-step procedure, that is taking 75 gram glucose and measuring the blood sugar 2 hours later. So that is the ideal test. So this is what is called 75 gram OGTT, and this should be performed at the first antenatal visit and repeated again between 24 to 28 weeks. Why it is so convenient for this test? Because it is irrespective of the fasting status of the antenatal woman. So here we should understand the methodology also, that women is given 75 grams of glucose in 300 ml of water, and we ask her to drink slowly on a span of 5 minutes, and plasma glucose is measured after 2 hours after the ingestion. If the women vomits within 30 minutes of ingestion, we have to repeat the test. The test has to be abandoned. And if the vomitings, if at all it occurred after 30 minutes, we can continue the test. So this is the test which is recommended by the Government of India under the GDM guidelines. WHO endorsed OGTT, taking 75 grams glucose and doing a blood sugar after 2 hours. So that is the test which have to be done. So glucose measurements can be done by a well-calibrated glucometer. So there is no need to take the plasma sample. We can do it with the capillary blood itself. What are the additional advantages? So why we are speaking so much of regarding this DIPSI method of testing? It is a single test. Single test in the terms that it serves both as a screening and diagnostic. Second, it is convenient and feasible. Most women, they don't come in fasting state for an antenatal checkup. So therefore, this test is irrespective of the fasting status, so it is convenient. It is feasible also because we just use a glucometer. It is a feasible test also. So these are the unique advantages of doing a DIPSI test as a screening test for GDM. So once, please look into this slide carefully. Suppose a woman has come for the first antenatal visit and we have done the 75 gram oral glucose and taken the sample 2 hours later. So that is a DIPSI test. If it is more than 140 milligram per DL, we label it as a positive test. So this lady is having gestational diabetes mellitus. We have to manage according to the GDM as per the guidelines given. If it is less than 140 milligram per DL, we have to repeat the test again at 24 to 28 weeks. If positive, again go by the GDM guidelines. If negative, you manage it as a normal antenatal case. So this is the universal testing for gestational diabetes, and see the cutoff, it is 140 milligram per DL. Then what to do? Suppose the woman underwent the test, screening test, and it is 140 and above. Yes, this is a case of gestational diabetes mellitus. Now, this patient needs to be educated. She needs to be educated why diabetes in pregnancy is a complicated issue. How it can complicate the mother, how it can complicate the fetus. So this sort of education is important. And the second thing is regarding the medical nutritional therapy and any drugs which will be given. What is the importance of glycemic monitoring very periodically, and what is the importance of fetal monitoring and planning of delivery. All these management issues have to be periodically be discussed with the antenatal mother and her partner, both of them. The first important thing in the management of gestational diabetes is lifestyle modification. So this lifestyle modification is a combination of medical nutrition therapy, which we abbreviate as MNT, and physical exercise. The combination of it is lifestyle modification. So here, this is the physical exercise which is convenient and which can be understood by antenatal mother and which is feasible. So we have to educate them that one can continue their daily activities, need not take additional rest. They need to do a daily exercise for 20 to 30 minutes, like brisk walking or any exercise involving the upper limbs. The antenatal woman is advised to choose such a physical activity which does not require standing or balancing. So apart from these two, any other exercise is okay. And she has to drink sips of water before and after the exercise to prevent any dehydration, and need to check the baby's movement before and after the exercise. So these are the simple tips for physical exercise which are convenient for us to educate the woman and also feasible for the woman to practice them. The next important thing is medical nutrition therapy. The goal of this is to achieve euglycemia, at the same time preventing ketosis, providing adequate weight gain for the mother and to the fetus. So while encouraging to have good euglycemic control, we also have to see that the mother will be gaining certain nominal weight in the pregnancy, and the fetus also should be growing to an appropriate extent. So these are the goal. And we have to plan the nutrition for the antenatal mother. It is the obstetricians who have to advise the proper nutritional plan. If it is difficult for them or if it is time consuming, we can always employ a dietitian to tell all these important rules. Nutrition therapy. The basic advice is follow discipline regarding meal timings. The antenatal woman has to eat food at the same time every day as far as possible. We need to advise her that she should not skip any meal. The basic rule is 3 main meals and 3 snacks. So that is the basic rule, which is to be given as education for every antenatal mother suffering from GDM. Ask her to have whole grains, fresh leafy vegetables, citrus fruits. So these are better than the other food items. Avoiding any deep fried items, sweets or juices. Eating heavy one meal and skipping other meals is not at all advised for GDM patients on nutrition therapy. So here is a wonderful pyramid which is showing that the top ones, that is ice cream, pastries, burgers, all these have to be avoided. And the bottom one at the base of the pyramid, that is fruits, fresh vegetables, milk. So these are the things which the woman has to eat. 50 to 60% of calories should come from the bottom ones. 10 to 20% from the dals, eggs, meat and curd, and 25 to 30% from oil, butter and nuts. So this is the basic thing, but it is difficult to explain to the woman regarding this percentage fashion. So this is the basic format, easily understood by the women. The composition of lunch and dinner thali. So here 50% of the thali should be having vegetables cooked or in the form of salad, 25% containing cereals, 25% containing protein, along with 1 serving of curd or a dairy product and 1 serving of fruit. So this is easily understood by every antenatal mother. These sort of charts can be put up in the clinic for the woman to understand better. The calorie allotment for a GDM pregnant woman is based on the BMI. So normally, if the BMI is less than 42, we can allow 40 kilocalories per kg per day. But if the woman is morbidly obese to the extent of BMI more than 30, then see it becomes 12 to 15 kilocalories per kg. So always understand that the calorie allotment is not static for all women. It is tailor-made for individual patients based on their body mass index. The carbohydrate intake also, we should give some advices that complex carbohydrates are to be recommended. The carbohydrate should be only to the extent of 30 to 40% of the total calories should be, from the carbohydrate should be around 40%, and from the protein should be 20%, and from the fat it should be around 40% again. And this, with this, if you are able to convince the woman regarding all these rules regarding the nutrition, 75 to 80% of women will be achieving normoglycemia. And the calorie distribution also, 30% of the total calories in the lunch, 30% in the dinner, and rest 30% in the form of snacks. But observe one thing, that breakfast should be having only 10%. So why this? Because carbohydrate intake in the breakfast should be limited, because insulin resistance is greatest in the morning hours. So for that reason, always we advise the woman that she should have only limited breakfast amounting only to 10% of the total calorie intake on that particular day. The next important thing is how frequently blood glucose has to be monitored. It's always better to have a home monitoring by a calibrated glucometer. And the woman is advised to maintain a logbook regarding the blood glucose values. And occasionally we may do hemoglobin A1C. It is only an auxiliary test which will give feedback to the patient. So how strict she was in controlling her blood sugar, and the target is 5.1 or less. So pregnant women with GDM, a confirmed GDM case because she was having more than 140 milligram per DL in the DIPSI test. So she is a candidate for GDM, and she was put on medical nutrition therapy. All these advices, what I've said, were given. And then after 2 weeks, so minimum period you have to wait is for 2 weeks, and we do again a 2-hour postprandial glucose. If it is less than 120, yes, your MNT has worked wonderfully. She will continue to do the same, and similar monitoring every 2 weeks will occur with 2-hour postprandial plasma glucose up to 28 weeks, and later on once a week. So that is more than sufficient. But if it is more than 120, even after 2 weeks after strict MNT, if the 2-hour PPBG is more than 120, that is a case where you have to start alternative therapy, that is probably insulin. Then coming to any other drugs which will help. If medical nutritional therapy has failed even after 2 weeks, failing means if it is more than 120, we can start metformin. So it is also given in the Government of India guidelines that metformin is a suitable alternative to insulin. To a maximum of 2 grams per day, metformin can be initiated, but with a tagline that it can be started only after 20 weeks of pregnancy, not in the first trimester at all. So with this exception, it can be started after, for cases who did not improve or become euglycemic with your MNT. But there are certain few side effects with metformin, like nausea, pain abdomen or bloating or distension, diarrhea, heartburn, possible attacks of hypoglycemia or lactic acidosis. So these are common, but lactic acidosis is quite rare. Even hypoglycemia is quite rare with usage of metformin. Metformin is a category B drug. It's a category B drug, means second and third trimester is safe and effective. And there were so many comparison studies with metformin and insulin in gestational diabetes mellitus. And it was found as a suitable alternative to insulin. There were no serious adverse effects with metformin in any of the studies done. So therefore, the next option after MNT is metformin. And look at this, metformin, the basic mode of action is it attacks insulin resistance, and you have wide experience in the form of various studies saying that metformin is a good alternative, but it doesn't prevent gestational diabetes, cannot manage severe cases. There is slight aspect of intolerance by antenatal women on metformin, can cross the placental barrier, but fetal risks are not yet understood. So these are certain aspects regarding metformin. If you consider insulin, it is highly efficacious, but with the disadvantage that it is in an injectable form. She has to take multiple injections. Hypoglycemias are common. Macrosomia is more common with insulin-treated antenatal women. Unable to prevent fetal complications like macrosomia. And it doesn't tackle the root cause. So those are the disadvantages with insulin. And now we have another group adding to the armamentarium, that is inositols. Inositols have a unique advantage that they can also prevent gestational diabetes apart from managing them. They are known to attack the root cause of GDM, that is insulin resistance. Favorable fetal and maternal outcome. Some studies have shown that they were superior to metformin alone. They were safer than both insulin and metformin in various studies. But the main disadvantage is that we need to have even more number of studies coming in to prove that inositols are better alternative or superior alternatives to metformin and insulin. Then coming to insulin. Initially, insulin was the only drug of choice for gestational diabetes mellitus. Even now, in many cases, it is the first drug of choice. If the initial fasting blood glucose is more than 110 or 2 hour is more than 200, it is a straightaway case we have to go for insulin, not for metformin. In any case where MNT fails, if you're not for metformin, yes, you have only one choice, that is insulin. Or if the metformin requirement has crossed 2 grams per day, you are left with no other option, you have to go with insulin. So this is the chart, a simple chart wherein even obstetricians can start insulin in their clinics. Pregnant women with GDM, not getting controlled with MNT or oral anti-diabetic drugs, 2 hour plasma glucose more than 120, even with those, then we need to start on insulin. Human insulin premix 30/70. So that is the format which has to be used. Subcutaneous 30 minutes before breakfast. So that is the initial dose that is advised. And this dose depends on what is the blood sugar. If it is between 120 to 140, 2. Between 140 to 180, 6. If it is more than 200, 8. So that is the values of insulin which is recommended. And then every third day, fasting blood sugar and 2 hour postprandial blood sugar have to be measured. And what are the cutoffs? 95 and 120 are the cutoffs. If after 3 days, if the fasting blood sugar is less than 95, the 2 hour postprandial is less than 120, yes, that insulin is sufficient. She can continue the same dose along with lifestyle modifications. So lifestyle modification continues even with insulin therapy. But look at the second scenario where fasting blood glucose is okay, less than 95, but 2 hour PPPG is more than 120. Such a case need to have an added insulin by 2 units before breakfast along with MNT. The third scenario where fasting blood glucose and postprandial are more than the cutoffs. In such a case, we have to give morning dose and evening dose and then manage. So like this, the insulin dosage has to be titrated against the blood glucose levels, and then you will get an optimum level of insulin requirement. When this optimal level has been reached, then the fasting blood glucose and 2 hour PPBG are measured every 2 weeks before 30 weeks and every week thereafter, and then the other antenatal investigations or surveys would happen normally. So this is the basic chart of insulin prescription for an antenatal woman. But what is more important is hypoglycemic attacks are very, very common. So all pregnant women on insulin can develop hypoglycemia at any point of time. And the definition for hypoglycemia is less than 70 milligram per dl. It is important for us to recognize the symptoms of hypoglycemia and treat immediately. So this is from the doctor's side. But for the patient side, how to recognize hypoglycemia needs to be educated to the woman and her family members. Early symptoms would be tremors of the hands, sweating, palpitation, hunger, fatigability, irritability, low attentiveness, tingling sensation. So these are the earliest symptoms. Severe symptoms are confusion, abnormal behavior, visual disturbances, anxiety. So these come under severe grade. So these symptoms have to be educated to the woman and more so to the family members attending on her. And how to manage hypoglycemia? So there are certain small tips which can be implemented at household level. That is immediately giving some glucose powder or sugar and ask her to rest, and then do the blood sugar again and then repeat it. Majority of the case, 99% of the cases, this sort of management with household items is more than sufficient. But some cases need to be referred. If the woman with hypoglycemia having severe nausea, vomitings, or in cases where fasting blood sugar is more than 200, fasting blood sugar more than 150, ppbase is more than 250, even with the maximum drugs you are giving, a total dose of insulin exceeding 20 units, or any time random blood sugar is more than 200, or the woman is facing recurrent episodes of hypoglycemia. So these are the cases which have to be handled by the physician or the endocrinologist. So these cases need to be having a multidisciplinary management. The other important advice to be given to the woman is regarding what are the steps in the storage and disposal of the insulin syringe and insulin vial. Remember, insulin vial has to be stored in the door of the refrigerator, never to be freezed. So it has to be stored in the refrigerator. On the vial, the date of opening of the vial should be mentioned, and because once opened, it has to be at any cost used within 1 month. And for the insulin syringe and needle, it can be stored at the room temperature, need not be kept in the fridge. It should be away from the children, should not be shared with anyone. And these syringes and vials have to be discarded or disposed appropriately. So the disposal of syringe and needle after one-time use, and collect the syringe and needle in puncture-proof closed container and bring it to the health facility for disposal or bury away from, out of reach from the children. So these are the simple tips we have to educate the women on insulin. Then the sites of insulin injections are depicted well in this figure. Only thing I would mention is human premix 30/70 is the easiest modality can be used. Insulin syringe should be of that 40 international unit syringe has to be used, and insulin vial containing 40 international units per ml. So this is easily understood by any partly educated woman also can be understanding all these particular rules. Coming to ionositols, we said these are emerging. What are these ionositols? These are the members of ionositol family are known to regulate insulin signaling. We have two important members of this ionositol family, that is myoinositol and dichirioinositol. So these are the two things which are there in the ionositol family. What are these gatekeepers? The myoinositol is necessary for the transport of the glucose up till the cell membrane. So that will be transporting the glucose to the cell membrane. Whereas the dichirioinositol, it stimulates the pyruvate dehydrogenase within the cell, and which is important to participate in the Krebs cycle. So that happens in the mitochondria level. So that is how the myoinositol and dichirioinositol, they help in the insulin signaling and also in the glucose uptake by the cell. So these effects are possible if the ratio between the MI and DCI are 40:1. So that is the ideal ratio where they can give the maximum possible physiological effects. Then there are, so these statements, what we are saying that the MI and DCI are very important, are told by many other proven studies. So these are all evidence-based. So in GDM, if we look, myoinositol has an ability to reduce the GDM incidence by 36%, and DCI also has the capacity to reduce GDM in 50% of the subjects. So this is one study which has proved that. And the second study which has proved that myoinositol and dicheiroinositol in the ratio of 40:1, that is the physiological ratio, diminishes the insulin resistance and normalizes the blood glucose level. So this is another study. The other important study which said that myoinositol 2 grams twice a day, that is 4 grams a day, can prevent gestational diabetes. So this is the additional advantage with myoinositols, that they have a capacity to prevent the gestational diabetes in the high-risk pregnant woman, which I have mentioned in my earlier slides. So they can reduce the GDM incidence by 80% and prevent macrosomia in 75% of the cases where 2 grams myoinositol has been given. There's yet another extended study which said that fasting glucose, fasting insulin, the insulin resistance, and adiponectin, all these factors can be managed by giving myoinositol 2 grams twice a day, that is 4 grams a day. So this was almost to say that is a meaningful decrease in insulin resistance in GDM cases by adding myoinositol. There is yet another extended study regarding the side effects with myoinositol. Myoinositol decreases the insulin requirement. Myoinositol decreases the maternal weight gain. Myoinositol reduces the rate of induced labor in a diabetic mothers. So these are all the studies regarding MI and DCI. Then there's yet another study which proved that the synergistic effect in the ratio of 40:1 by MI and DCI is far better than giving MI alone. So this has an additional advantage of normalizing the glucose in a quicker fashion, because if you see the myoinositol, how does it work, and the DCI, how does it work? MI works on at the cellular membrane level, that is a glucose uptake, and the DCI works intracellular at the mitochondrial level regarding the utilization of the glucose, making glucose into an energy format, that is the ATP. Regarding the safety profile, there are so many number of studies saying that inositol is quite safe during pregnancy, even with 4 grams per day, which the majority of the studies are saying 4 grams per day. No side effects have been reported in various number of studies, including those included Indian studies as well. So therefore, myoinositols, they reduce the respiratory distress syndrome, they reduce macrosomia, they reduce shoulder dystocia, reduced incidence of neonatal hyperglycemia and polyhydramnios, preterm deliveries. All these were studied in various studies, and these were the probable conclusions out of them. So all of us believe that the Cochrane group statements are very, very evidence-based for us. The Cochrane group has said or summarized the different studies and said that it appears that myoinositol shows a promise in reducing the risk of gestational diabetes, and it also reduces the insulin requirement or reduces the metformin requirement in a women who are put on insulin or metformin. So this was the conclusion drawn by the Cochrane group. So I think we can all think that it is almost evidence proved that we can add myoinositols to our GDM women. The next approach is regarding the antenatal management. Till now, we were speaking only about the glycemic control. So antenatal management starts from the first trimester itself. A very good ultrasound for dating the gestational age and proving the viability of the fetus is important as early as possible. The next important thing is, we know diabetes mellitus cases in pregnancy are more prone to have preeclampsia. So having known that, there is no harm in adding ecosprin 150 milligram for these cases to reduce the comorbidity of preeclampsia to these cases. Folic acid, anyhow, every antenatal woman would be receiving. All baseline investigations, and at 13 weeks, an additional scan for nuchal translucency, a double marker, and preeclampsia screening by uterine Doppler. So all these are important in GDM cases. Then ultrasound. Ultrasound plays a very, very important role in the management of diabetes mellitus. A baseline ultrasound at 18-20 weeks. So this is an anomaly scan. So we have to give information to the sonologist who is doing the scan that this is a case of gestational diabetes mellitus, and so that the sonologist can have a thorough look on the different organs which are expected to be malformed. So this has to be done at 18-20 weeks, and later on at 22-24 weeks, another scan for fetal echocardiogram. That is highly essential because cardiovascular abnormalities are most common and they may be missed when the scan is done below 22 weeks. Then from 26 weeks onwards, regular and periodic scan for the fetal growth and also for the amniotic fluid. Both are highly essential. And the third trimester scan, again for Liker and any accelerated growth to prove or disprove that the macrosomia is complicating. So periodic scans is a rule. Then regarding antenatal care, for those who have well-controlled blood glucose levels, you are not expecting any complications. So routine antenatal care as per the Government of India guidelines is more than sufficient. But for those women who are having uncontrolled blood glucose levels, that is the case where you expect some complications. So these cases need to have even more frequent antenatal visits, frequent ultrasound examination to see for the abnormal fetal growth or excess Liker in the form of polyhydramnios. All cases need to be monitored for hypertension. So we should not be lazy in checking the blood pressure every time. Every time the woman has to be checked for hypertension and proteinuria and other obstetric complications. In all relevant cases, antenatal steroids has to be given. And when we are administering antenatal steroid, these cases need to be admitted because we would be expecting hyperglycemia because of adding steroids. So therefore, better to admit her and then do frequent blood glucose estimation and adjust the insulin accordingly. Then a thorough fetal surveillance. Why I said thorough fetal surveillance? Because we know that fetal risks are far high in cases of GDM cases. So therefore, we should be very, very vigilant. So this surveillance would happen with antenatal NST, ultrasound examination for biphysical profile, ultrasound examination with Doppler 4 studies. So all are important, and so how frequently the fetus has to be surveyed is depending on the individualized case. So depending on the case, we decide how frequently fetus has to be surveyed. Then timing of delivery. So these are the general guidelines laid down by Foxy. A well-controlled gestational diabetes case on diet, we can deliver at 39 weeks. Gestational diabetes case on drugs, either insulin or metformin, need to be delivered at 30. We can extend maximum to 38 weeks. But poorly controlled GDM case, the timing of delivery is individualized. So whenever it is deemed necessary, it has to be terminated. Then the route of delivery, C-section versus a normal delivery. There are two basic indications per se for diabetes itself, that whenever there is a fetal macrosomia of more than 4 kgs, or when the woman is suffering from proliferative diabetic retinopathy, these two indications are straight away for cesarean section. In other cases, you need to judge depending on the pelvic assessment and cephalopelvic disproportion assessment. Then there are certain precautions which have to be taken for a planned delivery, either a C-section or a labor. Avoiding morning dose of insulin, avoiding long-acting and intermediate-acting insulins, monitoring blood glucose very frequently, as frequent as 2 hours throughout the labor, starting on plain insulin, short-acting insulin in a normal saline drip, and adjusting the dip rate according to the insulin sliding scale. What is this insulin sliding scale? Depends on the blood sugar levels, how much insulin has to be given, and this is to be added to normal saline, and what is the rate per hour. So everything is depicted on the insulin sliding scale, easy for everyone to practice it. So this insulin sliding scale should be pasted in all labor wards which are handling the GDM cases for delivery. Then a C-section will be there at the time of delivery. Why? Because birth injuries are quite frequent in these cases. So here in these pictures you can see, a brachial plexus injury with a policeman tip hand. The second film with an X-ray showing a fracture of the humerus, and the third one cephal hematoma. So here you can see a plumpy fetus with a congested face. So all these are relevant birth injuries possible in case of a large baby. So therefore, it is highly essential that a senior experienced obstetrician do these particular cases. Then what about the newborn? All newborns are at a risk of hypoglycemia. So we have to start monitoring in the first hour after delivery itself. This monitoring should take place every 4th hourly until you get 4 stable glucose levels. Until that point of time, it should continue. And the definition of neonatal hypoglycemia is less than 45 mg/cent. And intrauterine exposure of maternal hypoglycemia is very, very hazardous to the fetus in so many aspects. So mainly it is the hypoxia that can happen. So this hypoxia can lead to stillbirth, perinatal asphyxia, low Apgar score. Altered oxygen delivery to the fetus can lead to polycythemia because of increased erythropoietin. Hyperbilirubinemia is possible. Cardiac myopathy is possible. So all these are expected due to overexposure intrauterine environment due to the maternal hyperglycemia. So having known that so many things can happen, we should be able to evaluate all these in the newborn fetus. And you should be prepared to handle all these complications. Then what is the post-delivery follow-up? So immediate postpartum care is not much different from the regular antenatal women, but fasting plasma glucose and 2-hour postprandial plasma glucose has to be performed on the 3rd day after delivery. So that is highly essential. Should not miss that particular aspect. And GDM cases, please see that they remain in hospital at least for 5 days. Need not be discharged at 48 hours unlike other cases. And other important thing, we should be writing in the discharge notes that at 6 weeks postpartum, a full length 75 gram GTT, fasting 1 hour, 2 hour, 3 hour. Everything has to be completed and should be done at 6 weeks postpartum to label her as GDM or a case of overt diabetes. This is the most important test which need to be done. So therefore, the management of diabetes is simple and easy to practice. only then we will be producing a healthy mother and a healthy baby. But with a few tips. What are these few tips? Mandatory insulin institutional delivery, frequent follow-ups in the antenatal period and in the postnatal period, a strict, well-controlled blood sugar throughout pregnancy, maintaining optimal weight, identifying the maternal or fetal complications or the danger signs, and early referral to a high center in whichever case which is deemed necessary. So when we are practicing all these simple rules, then a healthy mother and a healthy baby is possible even with a diabetes complicating pregnancy. All cases, I said, once a woman is diagnosed as a GDM, she is at a lifetime risk of having a type 2 diabetes. So therefore, this woman should be counseled for lifestyle modification, weight monitoring, advise her annual screening, and if she is tested positive for diabetes, attach her to the non-communicable disease clinics as per the protocol. Pregnant women with diabetes and their offsprings both are at an increased risk of developing diabetes mellitus in later. So this counseling has to be given to all antenatal women regarding their lifestyle, their diet, and their regular physical exercise. Lifetime maternal risk for diabetes is 50 to 70% in the next coming 15-25 years for any antenatal woman who has suffered from GDM. So every annual or at least for every 3 years, it is mandatory that the woman get tested, and postpartum OGTT is very important. That's what I said. At 6 weeks, we have to do that particular test, the whole length 3-hour GTT, to label her as GDM or an overt diabetes. So thank you all for a very patient listening. So I think I've, at least to some extent, I've done my job. So right from telling you how important is GDM, how it is more relevant in our country, how it has become like something like an epidemic. From that stage to screening, to treatment, the postnatal care, and also adding that it's, so once a GDM case, it's a lifetime risk of developing a type 2 diabetes. So how to handle these cases, how to attach them to the NCD clinic later on. So thank you very much for your very, very patient listening, and I'm open for discussion. Any questions?
Yeah, thank you, ma'am. Thank you very much for your excellent and informative talk, madam. And thank you for updating us with that NHM guidelines. And it's always a honor to hear you, ma'am. So I would like to thank the participants for your patient listening. Madam, I will try to read out if there is any questions in the comment box.
Yes. Please do. Please.
Madam, there is one question like the insulin unit depends upon the body weight of the patient.
Insulin require. I didn't follow. What did you say? The insulin dose calculation.
Insulin units. Yes, ma'am. Insulin units. Whether it depends upon the body weight of the patient or
The blood sugar. It depends on the blood sugar values. I put it in my slide that it depends on the blood sugar. I'll project it again. So this is the thing I'll be projecting again. For you to understand, it depends on the blood sugar values, not by the body weight. So if it is anything between 120 and 140, how much units have to be given? If it is between 140 to 180, what is the dose? If it is more than 200, what is the dose? So this is the simplest way, as depicted by the guidelines, how an obstetrician herself can handle a particular case of GDM on insulin. But if it is more than 200, I think such a case has to be referred. So otherwise, it depends on the blood glucose values, not on the weight. But the calorie requirements is based on the weight of the BMI of the woman.
Okay, ma'am.
Okay.
Ma'am, one more question is like for high risk patients, madam, like if the patient is already diabetic and the GDM is identified in the first trimester, what will be the advisable treatment, ma'am? If there is uncontrolled diabetes, what will be the treatment option?
No, if the patient herself knows that she's already a diabetic, before planning the pregnancy, she should be having a thorough preconceptional counseling and see that the hemoglobin A1C is less than 5.1. So that is the ideal advice that has to be given. But if she has conceived with an abnormal blood glucose levels, or as depicted by hemoglobin A1C, if it is more than 8.3, so that will put the case into a high risk category for congenital abnormalities of the fetus. So such a case should be counseled regarding continuation of the pregnancy, explaining her the risk of the congenital abnormalities which would occur. So if the women opts for a medical termination of pregnancy, she'll go ahead. Or if she wants to continue, we need to have a thorough anomaly scan and the other investigation to see whether the fetus is normal or abnormal, and then she will proceed with the further management of the pregnancy.
Okay, thank you, ma'am. And there is one compliment from Dr. Kamala Ganapati Appan that she says that the presentation was excellent, madam.
Thank you so much.
And ma'am, I don't find any other questions in the comment box, ma'am.
Okay.
So if you allow us, then we can wind up the today's webinar.
Yeah. Okay. So
Yeah,
Thank you
thank
so
you.
much, ma'am. And thanks so much.
Thank you very
all
much
the
from my
doctors
side
who
also
attended.
for involving me in this topic. And I'm very, very fond of this topic. Once for the South Asian Conference of Diabetes in Pregnancy, I've gone to Sri Lanka also.
Okay.
So that is why I think I have certain extra knowledge regarding
That's
this
great.
gestation diabetes, right from screening to management and later on. So thank you very much for involving in a topic which is very, very relevant and very close to my heart.
Thanks
yeah,
so much,
ma'am.
ma'am.
Yes, ma'am. There is one more question from Kamala Ganapati Appan. Is there any precautions to prevent GDM for second pregnancy?
No, actually, in my slides also I put, so probably myoinositols might be helping. Probably myoinositols might be helping. Apart from that, the woman has to be managing good lifestyle modifications, like physical exercise and then her diet. So that might be more preventive to prevent GDM in the second pregnancy. So those lines have to be educated well to the woman. So that is my way of approach.
Okay, ma'am. There is another one compliment message from Dr. Jayashree. Again, she says that the presentation was excellent, ma'am.
So thank you.
Yes, ma'am. Then if you allow us, then we can wind up the session, ma'am.
Yeah, please.
Yeah,
So thank you.
Thank you for your presence, ma'am. Thank you for spending your valuable time with us, and hope we'll be having another session in future, ma'am.
Thank you.